Thank you, thank you, thank you. It's good to open this Hepatitis C Policy Forum. It's great to get together, share lessons learned about what is working to advance our progress toward elimination, what are the challenges, and how we can work together to overcome them. And that's the whole purpose of APASL. That's the whole purpose of the Coalition for Global Hepatitis Elimination, and that's why we're working together to convene this policy forum. We have a very robust schedule of speakers. We have ample time for discussion, and we look forward to having a real interchange of our experiences and our ways forward. This is our agenda. You'll be hearing from Professor Kato in just a moment. We'll be having a video message from the Minister of Health of Japan, followed by comments from Philippa Easterbrook and myself to set the stage for some presentations on particular aspects of how to deliver hepatitis C testing and treatment services for various populations, whether they be for persons with substance abuse disorders, persons with diabetes, a general population strategies, the importance of policies to direct and scale up hepatitis C testing, and then having a discussion where leading to a call to action that I'll be describing more in a moment. As part of our opening, I will turn it now over to Professor Naoya Kato, Professor and Chair of Department of Gastroenterology, Graduate School of Medicine at the Chiba University here in Japan. Thank you.
Thank you, Professor Wald, for kind introduction. And slide, please. My slide, please. Good afternoon, everyone. And this HCV Elimination Policy Forum, I'd like to give opening remarks. As you know, this is key factor of hepatitis C. HCV can cause both acute and chronic hepatitis, and also lifelong illness, including liver cirrhosis and liver cancer. And HCV is a blood-borne virus, and most infection occurs through exposure to blood from unsafe injection and unsafe health care and screening blood transfusions, and importantly, injection drug use, and also sexual practices that lead to exposure to blood. And globally, an estimated 58 million people have chronic HCV infection, with about 1.5 million new infections occurring per year. And WHO estimated that in 2019, approximately 300,000 people died from hepatitis C, mostly from cirrhosis and liver cancer. And DAAs can cure more than 95% of patients with HCV infection, but access to diagnosis and treatment is unfortunately low. And there is currently no effective vaccine against HCV. And this slide shows the HCV infection in the world and also Southeast Asia in 2015. This Southeast Asia region, around 0.5% of people are infected with HCV, namely 10 million persons are living with HCV, and still 300,000 persons are newly infected by HCV annually. So between 2015 and 2030, WHO targets include reducing new HCV infection by 80%, and also reducing HCV deaths by 65%, and increasing HCV diagnosis from less than 5% to 90%. and the number of eligible persons receiving HCV treatment from less than 1% to 80%. This slide shows the cascade of care for HCV infection by WHO region 2015. About 71 million people are infected, and this part is Southeast Asia region. And the 2030 target, 90% infected diagnosed, but now only this part is diagnosed, but more than 70% is undiagnosed. In the 2030 target of WHO, 80% of diagnosed treated, but still only small percentage of patients are treated and also cured. So we have a good DAAs. So now the DAAs become pangenotypic and very effective. No live wiring required, and also minimal pre-treatment assessment, and also high barrier to resistance. And short duration, 8 to 12 weeks is enough. And once daily dosing, and minimal or no on-treatment monitoring, and easy to manage drug-drug interactions. So I final message is moderated from CGHE homepage to avoid the dire consequences of inaction. It's a time for all countries to accelerate steps to eliminate hepatitis C. Thank you for your attention.
Thank you. Thank you very much. Excellent comments, setting the stage for our discussion. I think it's also our privilege to introduce a video message from the Minister of Health, Kizo Takimi. So let's hear from the minister.
皆さん、こんにちは。参議院議員の武見敬三です。本日、第33回アジア太平洋肝臓学会年次総会にご出席の皆様には、日頃から肝臓疾患に関する基礎的、臨床的研究を奨励し、肝臓学の向上や社会の福祉増進に大きく貢献いただいていることに、心から敬意を表します。我が国には、肝炎ウイルスに感染し、あるいは肝炎に罹患した方が多数存在し、国内最大級の感染症となっています。これまで医療の進歩、医学的知見の積み重ね、科学技術の進展により、肝炎の克服に向けた道筋が開かれてきました。我が国においては、血液凝固因子製剤に C 型肝炎ウイルスが混入することによって、特定多数の方に感染被害が生じたこと、また集団予防接種の際の注射器の連続使用によって B 型肝炎ウイルスの感染被害を出したという歴史があります。このような現状において、肝炎ウイルスの感染者および肝炎患者の人権を尊重しつつ、良質かつ適切な医療提供を確保することなど、肝炎の克服に向けた取り組みを進めてきたところです。我が国では、平成22年に肝炎対策基本法が施行され、この法律に基づき制定された肝炎対策基本方針により、肝炎ウイルス検査、肝炎医療、研究、普及、啓発などの肝炎の総合的な対策を進めてまいりました。近年では、C 型肝炎のインターフェロンフリー治療薬の開発により、高い確率でウイルスの排除が可能となり、平成20年に開始した肝炎の治療に対する医療費助成について、平成26年からはインターフェロンフリー治療も対象とするなど、助成の対象を拡充してまいりました。慢性肝炎、 肝硬変を背景に発症する肝がんの成因は、1990年代全般までは C 型肝炎ウイルス感染に起因するものが7割を占めていましたが、こうした取り組みの結果、その後はその比率が減少をし、肝がん死亡者数、罹患者数も減少傾向にあります。世界保健機関の2016年の総会で、2030年までに公衆衛生上の脅威としての肝炎ウイルスの排除達成という目標が掲げられました。このような中で、とりわけ C 型肝炎ウイルスについては、各国が WHO の掲げる目標の達成に向けて取り組んでいるものと承知をしています。我が国においても引き続き、肝炎総合対策を進めていくことにより、肝炎の克服に向けて取り組んでまいりますので、本日お集まりの皆様の変わらぬご尽力を心よりお願いを申し上げます。結びといたしまして、当会のご成功と、本日ご参加の皆様のますますのご発展を記念申し上げ、私の挨拶とさせていただきます。厚生労働大臣、武見敬三でございます。
Thank you very much. I'll now turn it over to Professor Kato to moderate the first session.
Okay, I'd like to start first session, updates on progress towards HCV elimination. And the first speaker is Dr. Philippa Isabrook. She's senior scientist, Global Hepatitis Program, Global HIV, Hepatitis and STIs Program, World Health Organization, Switzerland. So her topic is status of HCV elimination globally and in Asia. So, Dr. Isabrook, please.
Thank you very much, and thank you for the opportunity to speak at this session. And so, in this short presentation, I think my role is really to set the scene and to provide a global perspective from the WHO angle, and looking at some of the activities and the products and the guidance that have come from WHO, and some of the new products that are coming soon, which it's important for you to be aware of. So I will be touching on the global strategies, the global progress report, which is coming soon, the new strategic information guidelines coming soon, and then to spend a little time on our guidance for countries on validation for the elimination of viral hepatitis B and C as a public health threat. And there was an update to this in the last year. And again, it's something we very much want to promote and encourage countries to submit. And then to finish with a summary of the hepatitis C guidelines for simplified care that were published in 2022, just to remind you of the key messages. So to begin at the beginning, and the minister has already alluded to where it really started in 2016 in terms of WHO engagement with the first global strategy for viral hepatitis B and C, which set ambitious targets towards elimination of both viral hepatitis B and C as public health threats. And this was based on particularly modeling work, which demonstrated that through the scale up of 6 synergistic preventative interventions, as well as testing and treatment, that elimination was indeed feasible, and set out those targets for program targets in order to achieve the impact targets for elimination, with the 65% reduction in mortality, 90% reduction in incidence. Well, since then, there's been a new strategy, and this was an integrated strategy for both HIV, viral hepatitis, and STIs. And that reflected the merger and acquisition of the HIV program at WHO, which brought in hepatitis and brought in STIs. And this really strategy played to the synergies across those diseases, as well as some of the distinct features. So there were 5 strategic directions. And I think just to highlight, it's shown in the green box, the particular challenges and particular shifts required if we're to achieve elimination of viral hepatitis. And that really included promoting much greater public awareness in the community, as well as among healthcare workers, as well as political advocacy, the importance, the absolutely critical importance of community and civil society engagement, the need for scaling up for hepatitis B, access to birth dose, which is indeed now happening, and promoting the increased access to the testing and treatment, a simplified care model with decentralization as well as integration of services, and the issue of financial resources being allocated at a national level. And I think this slide really just summarizes those same messages, but put into a framework of the key inputs and interventions needed, what the particular outputs and outcomes would be, and the key impact, which is ultimately to achieve the end of AIDS, as well as the epidemics of viral hepatitis and STIs. And this is a table which summarizes and outlined in red are the targets for hepatitis C, that presents the targets for 2025 and for 2030, both in terms of the % reduction. The original metrics were relative reduction, as well as relating that to the absolute targets for both new infections, the incidence, the mortality, as well as the program targets for testing coverage, treatment coverage, and for the main preventative interventions. So we published in 2021 the Global Progress Report, and that was based on data available up to the end of 2019. And that's what's shown on this slide. And on the right, showing the cascade data for both B and C, which you saw in the earlier presentation. In a week's time, there will be new data, both in terms of global burden and in cascade data and by region. And unfortunately, I had to change the slides because they're in fact embargoed until the 8th or 9th of April. But I think I can certainly share that for hepatitis C, there's a further reduction in the burden, as you would expect, relating to the significant and sustained scale up of treatment, although that's more in certain regions where that's happened. And in terms of the cascade data, again, a continued improvement in coverage of testing and treatment. Hepatitis B, though, continues to fall significantly behind the progress with hepatitis C. So what else is coming? Well, I'm going to mention in a few slides about the updated guidance for country validation of viral hepatitis elimination, shown on the left. That came out about a year ago. There's now a new framework for a really important initiative of WHO, which is the triple elimination of mother-to-child transmission, HIV, hepatitis B, and syphilis. We're doing a lot of work in this area to promote that. There's going to be the new hepatitis B guidelines, which I will be presenting and launching on Saturday in this room at 10:50. And then I've mentioned the Global Progress Report, which will be launched at the Viral Hepatitis Summit in Lisbon in about a week's time. And there's also going to be consolidated guidelines for strategic information for viral hepatitis that's coming soon. So I'm just going to mention about the elimination guidance. So these were first published in 2021, and guidance for pursuing elimination for hepatitis C, hepatitis B, as well as mother-to-child transmission, so different options for countries. And then this was further updated with some significant changes. And I've actually been to a couple of presentations already where I have noted that people are still showing the table of the key metrics for validation that were from the original guidance. So it's important you're aware, and this table is a summary of that, of the all the impact targets, that's incidence and mortality, and the program targets for B, and on the right for C. And the main difference with C now is that, well, both B and C mortality is we've combined the mortality target. So it was less than 2 per 100,000 for C, and it was less than 6 for hepatitis B. And now we've combined those. So it's overall less than 6 per 100,000. And the incidence target remains the same. So next slide. We did some country pilots before we updated the guidance from a range of countries. And I think some helpful and not unsurprising feedback that measuring incidence, particularly in relatively low prevalence areas, can be challenging to demonstrate you've met that metric. And the general strategy is to retest the negatives in order to get your estimate of incidence. In terms of mortality, particularly in low and middle income countries, not surprisingly, it's recognized that death certificates in cancer registry often fail to capture hepatitis B and C as an underlying cause of death. And so a strategy we've been promoting is using sequelae surveillance, and many countries are now doing this. So with cases of cirrhosis or HCC, being able to attribute what proportion are due to B or C, and this can be used in projection of really liver-related mortality. So one thing that is new in the updated guidance is that we now have a path to elimination. And this path to elimination, rather like the Olympic medals, there's a gold, a silver, and a bronze. And this is really to recognize those countries that may have very high burden, that are making important progress in their programs, but are still some way off achieving those mortality, in particular mortality targets, recognizing it's often a 20-year lag between scaling up treatment and showing an impact on mortality. So these are program targets alone, with incremental percentage coverage from bronze, silver to gold, in order to be able to recognize the great responses that have been made in some countries. And I think it was a wonderful moment when we were able in October to award Egypt as the first country to receive the WHO Gold Tier for hepatitis elimination, and the Director General came with us and presented to President al-Sisi. And in fact, we won our own small award for being part of a 3-level WHO response to support the country in achieving that goal. So what will it take to achieve elimination? I think this is just another simplified framework of really all the good practices that really we're encouraging countries to adopt, to have that holistic approach in their response, covering political leadership, the strategic planning, the driving down prices of drugs and diagnostics to promote access, and simplified service delivery. And I think on the right is just the very nice framework that the Clinton Health Access Initiative uses to approaches to building a hepatitis public sector response. So I'm just going to finish with a few slides to remind you of our key messages on the simplified service delivery diagnostic innovations for the Hep C response. And so just as with HIV, there's been a continued evolution and progressive simplification of our guidelines. And with the adoption, obviously, of a treat all pan-genotypic regimens, and then simplifying to 3 preferred regimens, Sof-Dax, LNGP, and expanding treatment to down the age groups, first to include adolescents, and then in 2022 down to 2 to 3 years. And then we initially had good practice principles for simplified service delivery, but with the growing evidence, we're able to issue formal recommendations for decentralization and task sharing. And similarly, on the diagnostic side, with the use of a point-of-care viral load assay as an alternative to lab-based and reflex viral load testing. So these were the recommendations for children, reconciling the same regimens that have been proposed for adults for use in adolescents and children. I think the major challenge we're facing is really a systematic approach to case finding to enable these children to benefit from treatment before they become sick. So particularly ensuring that all children, the offspring of Hep C positive parents, are tested. In terms of the service delivery, the main messages being we recommend both the testing and the treatment can be done at peripheral health or community-based facilities, and ideally at the same site for the testing and treatment. And this could be primary care, harm reduction sites, prison ART, as well as in the community, and to integrate. So where you are decentralizing, to integrate the Hep C testing and treatment as part of existing services, including harm reduction measures. And for task sharing, recommending delivery of testing and treatment by non-specialist doctors and nurses who've been trained. Clearly, many implementation considerations. And not every country is going to wish to decentralize, and the decentralization and simplified service delivery needs to happen alongside all the other community engagement, efficient procurement, and supply chain. Task sharing clearly requires the appropriate training and mentorship, and ideally within the framework of a differentiated care model, just like with HIV. Those who are well and stable can absolutely be managed at the peripheral health sites. In terms of the diagnostics, the main recommendations, the ones on the left, are the 2017 testing recommendations. And really, we are now promoting hepatitis C self-testing. And as I mentioned, the point-of-care viral load for both detection of viremia and test of cure, use of dry blood spots as appropriate, and reflex testing. Implementation considerations, again, national programs need to look at what would be the strategic positioning, where the point of care would best be used versus the laboratory-based, and with a particular priority for those sites where there's maybe high loss to follow-up, harm reduction sites, persons who inject drugs, where fast tracking of the diagnosis. And the ultimate placement for the point of care instrument is where testing and treatment are at the same site, a one-stop shop. And we've been able to demonstrate from testing to treatment can be a matter of a couple of hours. And the opportunity, of course, to integrate using multi-disease platforms. And with reflex testing, same applies. It can be laboratory-based if that's where your serologic testing is done in a lab, and immediately reflexing a positive result to the use of doing viral load. And I think just as an advance notice, we're adopting the same simplification approach with the new hepatitis B guidelines on the who to treat, the antiviral regimens, the antiviral prophylaxis, simplifying diagnosis, simplifying service delivery. This is a quick look at the shift in the algorithm where we're substantially expanding the proportion of Hep B surface antigen positive who will be eligible compared to previously. To thank my many colleagues and to also just leave up the slide on the session for Saturday. So please do attend, and looking forward to your feedback. Thank you.
Thank you, Dr. Eastbrook. And the next speaker is Professor John Ward, and he's a director and coalition for global hepatitis elimination. So, Professor John Ward, please. His topics is national advances towards HCV elimination in Asia.
Great. Thank you. Thank you again. I want to thank Philippa for setting that stage and really describing WHO's really excellent efforts of providing a framework for quality of delivery of the services needed to eliminate hepatitis. What I'll be doing is now shifting our focus more toward a national level and what's going on here in Asia before we take that next step and learn from at the local level different options for delivering testing and treatment for hepatitis C. At the US CDC, we used to say all public health is local, and I believe that's true for hepatitis C elimination, and we'll be seeking to progress from the global to the national to the local. These are my disclosures. Again, I'll be looking at different what's going on at the national level here in Asia, and the importance of working together in that regard. As was touched on by Professor Kato, we have about 58 million people living with hepatitis C globally. About half of those are living in countries of the Southeast Asia and Western Pacific region of WHO. About 40% of the mortality globally are in countries of Asia, and almost about 1 out of every 3 new infections are in the countries in these regions. So really a lot of good reasons to target hepatitis C for elimination. We can have a great health impact, again, in the countries of these 2 regions with preventing over 666,000 deaths, 8.4 million DALYs averted, preventing 2.8 million new infections by 2030. All of these interventions would be cost saving, and perhaps very important to governments. There is a consequence of inaction, of failure to eliminating hepatitis C and lost productivity from premature mortality and disability. And that can not only be reversed, but you can also get economic gains by seeking and achieving goals for hepatitis C elimination. And as was touched on by Professor Kato, we just put out a report on the consequences of inaction and how to overcome them. That's available on our website at globalhep.org. And I think there was one of the reasons that these economic consequences, one of the reasons that the G20 in their New Delhi declaration this past fall called out the need to continue to have progress toward ending hepatitis when they looked at coming together as an economic bodies. At the coalition, we really recognize from the experience of other disease elimination programs, particularly those that have been run by the Task Force for Global Health, where the coalition resides with their experience in polio, smallpox, measles, that there are key components that make disease elimination and hepatitis elimination programs effective. The good data to guide policy development, that can also help national planning, the engagement of political leaders, the pilot testing to tailor strategies, a focus on health equity, which is really the only way you can achieve goals for hepatitis elimination, is for everyone to benefit in a community or a province or a country. Integrating hepatitis services within existing health systems, so whereby hepatitis elimination is strengthening the health system as you move forward. Seeking financing so you can sustain your progress toward your goals or achieved. The importance of operational research to always look for ways that you can improve how you are conducting your activities, and hopefully we'll be learning some from our presentations to follow, and then having data to recognize when your goals have been achieved. As part of that effort over the last 2 years or so, we have put together profiles of hepatitis elimination programs now in about 33 countries, including 12 here in Asia, as is noted in the map there on the left, with profile underway for Australia and India as well. And this brings together the status of data, planning, policy development, program development, implementation of these key interventions to prevent, test, treat, and cure hepatitis C. And then in so doing, recognizing the achievements, the gaps, and important next steps. Again, this just, again, reemphasizes key data regarding the prevalence of hepatitis C in various countries and the variability therein. So again, emphasizing the importance of good quality data. This shows you for mortality data that's reported by the countries as well as Taiwan for these national hepatitis elimination profiles. 2 countries appear to be close to achieving the goal, or really have achieved the goal for mortality reductions for hepatitis. That's Japan and Korea, with three reporting, Chinese Taipei, Japan, and South Korea reporting declines in mortality since 2015. So we need greater mortality declines in the remainder of those countries to really accelerate progress toward hepatitis elimination. And with all that said, as Philippa touched on, we really have an issue with quality of data to guide our work. Incidence tracking is a real challenge for hepatitis C because of the silent nature, clinically silent nature of acute infections. Mortality data often does not include the cause of liver cancer or cirrhosis. So that's a particular challenge, and relatively few countries have systems in place to track the number of people tested and treated. So that's a key focus area, but I think it's also important for all of us when we look at data to be cognizant of those limitations and to delve in and see where that data is coming from. Is it coming from a national registry, a serial survey? Is it just modeled data, et cetera? Based on the data we do have, we have some improvements in access to hepatitis C screening and treatment, as shown here. We have some role models such as Australia, for example, Chinese Taipei, that are achieving high rates. And we're going to learn a little bit more about about Taiwan here in a moment. But we have some work to do, and we cannot cure people if we're not testing them and linking them to care. Fortunately, many of the restrictions that were put in place years ago because of the concerns regarding the price of HCV medications have fallen away. A large global survey of countries that we were part of as a coalition, along with our colleagues at the Kirby Institute in Australia, that was released in Lancet GastroHep. It's online now, will be released formally in April. Shows that many countries have already dropped many of these restrictions, as shown here, although not all, with treatment copays continuing to be onerous, particularly for low and middle income countries. And so there are some areas for improvement, but there has been improvement compared to when the curative era first began. We also need better access to safe injection equipment for persons who inject drugs. Now, fortunately, in Asia, as you can see here, a number of countries are achieving high rates of access to clean injection equipment, but more work needs to be done in that area to lower the rate of HCV infection among the population at highest risk, in combination with other harm reduction strategies, as shown here. Now, Japan has been a role model with policies for broad access to hepatitis C testing, which we'll be hearing a little bit more about in a moment, and decreasing many of the barriers to access to testing and treatment over the years. That said, they still have only diagnosed about 44% of the people living with hepatitis C. So it's really important to continue to sustain your efforts until your goals are achieved, even as you have a very mature program. It was great to hear the minister continue to express that commitment. Again, for Taiwan, has put in place many of the testing policies, such as universal access to testing, that really helps to make testing widely available and lowering many of the barriers to access to treatment and making treatment available at the primary care level and not just at the specialty level. We can't, as we think about countries doing well, we have to be cognizant also of the countries that are just beginning on this hepatitis C elimination journey, such as Vietnam, which has a national plan, is doing a fairly good job of making clean injection equipment available. It's doing pilot programs to see how to integrate hepatitis C testing and treatment in those programs, but it has some work to do to lower the cost of treatment as well as testing so that everyone in Vietnam can benefit from testing and treatment. Another excellent example of a national program is South Korea. They, as you can see there in the middle column, they have are moving toward a broad scale up of hepatitis C testing. They have again lowered, seeking to simplify access to testing and treatment by making it available at the primary care level, but they still have some work to do in providing harm reduction. And working with them to identify their key next steps. Those are listed here on the right, particularly with that focus on scaling up hepatitis C testing as part of their annual preventive medicine checkup. So, all of these components are important, but to really do a great job, you really have to really put those into action. That national commitment is really, really important. And that's why that message from the minister is so important, to show that national commitment that helps begin to put those policies into motion in a country like Japan. In that regard, we have put, over the last several years, working with the WHO office in New York, we started a UN group of friends to eliminate hepatitis. A group of friends in the UN is a way countries come together on issues of common concern. There had not been one for hepatitis elimination previously, so we started that in the September of 2022 at the UN General Assembly, and we repeated it in September of this past year. And it's my pleasure and honor to have the Nobel laureate Harvey Alter help us in that effort. This is him providing remarks, and we have others in the room who have been part of those events. And we are growing that group of friends. We now have over 41 countries that have expressed an interest in joining the group of friends, with Egypt, Chile, and Portugal serving in the leadership circle for that group of friends. In that regard, I wanted to play some comments from Dr. Youngmi Ji, Commissioner of the Korea Disease Control and Prevention Agency.
Republic of Korea stands ready to tirelessly work with the international community in our joint efforts for achieving the UN SDGs and WHO's goal of eliminating viral hepatitis. We are strongly committed to share our experiences and lessons learned in controlling viral hepatitis and key strategies with other member states.
That's what we want to have happen here, is not only to have a scale up within the country, but be open to sharing your expertise and perhaps your resources with others, so we can truly have a global community working together to achieve these goals for hepatitis elimination. At the end of this session, we're going to have a call to action that I would like all of you, frankly, to sign. I'll be presenting it at the end of the program. Please stay around for that, because I think we need to show that evidence of a global community coming together in Asia, where hepatitis C is such a major problem, and there's so much to gain in economies and in health by achieving goals for hepatitis C elimination. So please stay and join me in signing this call to action at the end of the program. Thank you very much.
Thank you, Dr. Ward, for excellent presentation. And now the time to wrap up this first session. So I'd like to pass the chair to Professor Tanaka. Professor Tanaka, please.
Okay. Okay, ladies and gentlemen, my name is Junko Tanaka, Executive Vice President of the Hiroshima University. I am in charge in the PI of the research group under the Ministry of Health Japan. So this session, we will introduce two speakers of the Professor Grace Wong and Professor Yang Queen Chao, right? And this session is HCV elimination initiatives to reach marginalized communities in Asia Pacific countries. As the previous session, we of course understand that the HCV elimination is going on owing to the developed very good DAA treatment or something. But we have some issues remained in the marginalized communities, how to treat them and how to make them a good link of care. So this session, they will give a good speech from their specialized. So I'd like to introduce Professor Grace Wong. So she is a professor of the Chinese University of Hong Kong, and her research interested including big data research in hepatology, chronic viral hepatitis, and risk reduction of hepatocellular carcinoma. Okay, let you start.
Thank you. Thank you, Professor Tanaka, for your very kind introduction. Good afternoon, ladies and gentlemen. It's my great honor and pleasure to be part of this very important HCV policy forum, which I think a lot of things have been done, but still a lot we have to do. So I will be quite focused on some work that we have been doing in Hong Kong to how to manage some quite difficult to manage people who use drugs. Some of my disclosures. We repeatedly see this very important slides that hepatitis, chronic viral hepatitis still kills a lot of people. So over the last nearly 10 years, we have been working very hard to reach these goals. So I would say that now probably half the time, like 7 to 8 years have gone, and we still have another like 6 years to reach the time point of year 2030. That what we have been doing and any other things we have to do. So in fact, our government in Hong Kong, we have been like very closely monitor our achievement with some benchmark, focusing on the hepatitis C things like the diagnosis rate, treatment coverage. I would say that we're kind of doing quite reasonably well because the cohort of patients with chronic hepatitis C in Hong Kong is not that large compared to Hep B. So that's why I think we are kind of past our midterm assessment, you may say, that we are setting the targets that by 2025, we are almost like surpassed a little bit. But I also have to highlight that to achieve to the goal set by year 2030, even it's a small part, but usually these will be the most difficult, challenging parts, that how can we further improve our diagnosis rate and treatment coverage? So what things we can do better in the coming few years? So we are keep learning from some excellence model around the world. This is one good model from the UK. They use this rapid point of care test as well as very short course DAA. So just now, I think Dr. Easterbrook also highlighted that, in fact, point of care test is something very helpful to streamline the assessment, and then we can start the treatment right away, right at the spot. So this is something that this is from Australia, that this model have been working very well, that in fact, the treatment uptake rate can be very high as 92%. And this is something that we are learning. So in Hong Kong, we have this program. In fact, it started quite a while ago, since year 2009, which at that time we only had PAC-RIBA, but we at that time, we started this program aiming to increase the screening rate. So that's why we partnered with some NGOs in Hong Kong. We access to people. In the old days, we focus on those already quit using drugs, but in more recent years, we also included active users. So we keep doing workshop, education program, and in fact, in parallel, while we are giving talks, next door, our colleagues will do the finger prick test. In the old days, we only did the anti-HCV, but in more recent years, we also use a gene expert to also assess the HCV RNA level right at the spot. And I also highlighted in Hong Kong, our government set up the steering committee on prevention and control of viral hepatitis in year 2018, which is a while after the WHO call for hepatitis elimination. So we included a group of experts, high officials, that hopefully we can gather some good brains to set up a very good strategy apply locally. So like, for example, two of my mentors, Professor Henry Chen and Professor Vincent Wong, they are the members of the steering committee. And down this steering committee, we also have some working groups, like myself and Vincent. We are also the members of the clinical working group. We will set some actions that we can really work better at different levels, screening, management, linkage to care, and so on. So that's why how we try to put some efforts forward. So this is an old photo. So you see people still wearing masks that time, because it was in year 2020 that it was the first year of COVID outbreak. But at that time, our government took this efforts to have this Hong Kong Viral Hepatitis Action Plan, which covered the last 5 years. So in fact, another action plan will be available very soon. I think that was the time point that we expanded our treatment coverage to all patients with detectable HCV RNA. They will be eligible for DAA treatment, fully funded, fully covered. So I think that time was a big step forward for managing patients with HCV. And this is the model that we adopted from very similar to the Australia model, that we use this test and treat pilot program. So the whole process just take like one morning. So, but I have to highlight, we need a lot of effort from our social workers, our NGOs partners. They gather the people, like a group of 8 to 10. They come together to our center. So we on one spot, we would do the finger prick test to have the gene express, which runs for like 15 minutes. And then at the same time, they will watch some video, and also we do fiber scan on them. So we can have all the steps streamlined within like a couple of hours. When the HCV RNA results available, then we can start the DA treatment right at the spot. So everything can be finished within one morning. So I think with this very streamlined program, in fact, we successfully treat quite a handful of patients, because we can do everything at the same spot. So at the same time, we also have another model, is a fast track HCV clinic, which may not everything happen in the one morning, but still we will accept some referral that they have either positive HCV RNA or anti-HCV. Then we will refer to the patients to our clinic within like a couple of weeks. And then we try to also skip a few steps that measure the blood test as well as do fiber scan within a very short period of time. And then we start the treatment very soon. So I think these two models also try to improve the treatment uptake rates, and also the decrease the rate lost to follow up. So over the last 1.5 years, we partnered with some of our sister hospitals around our region, as well as some direct referrals from NGOs. Then at the end of the day, you can see the last 3 rows that in fact, among those patients with detectable HCV RNA. In fact, the number of referral, treatment uptake rate, and treatment success rate is very high. So which is in fact much higher than this program started before. So which means that in fact with this streamlined approaches, we can hardly improve the DAA treatment uptake rate as well as this treatment success rate. So this very short presentation share with you some of our current practices. So definitely we wish to do more. Example, those who not yet diagnosed, hopefully we can further improve the diagnosis rate. So I would also love to share with you this website. In fact, it's one of the platform that we educate our public, general public, or any people who are interested in liver diseases. So in fact, just if you come across someone who can read Chinese, feel free to visit these websites. We have a lot of articles about HCV as well as other liver diseases. So with that, I thank you very much for your attention.
So thank you very much. The question is, okay, after that. Okay, thank you very much. So next speaker is Professor Yanko. He's a senior consultant, Department of Gastroenterology Hepatology, Tan Trak Sang Hospital, Singapore. So, okay, please start.
Thank
your
you,
presentation.
Professor Tanaka, for your kind introduction. I'm Guo Chao Yu from the Tan Tock Seng Hospital, Singapore. So today, I thank you to the APASL and also the Global Task Force for your invitation to talk about simplification of hepatitis C care in Singapore. I would like to share with you some of the insight that I can gather from the Educate, Test and Treat program. So this is my disclosure. So if you look at how we actually molding outreach program, and every nation or every district of nation would have some issues with how to actually design the model. So essentially, I come across this systematic review and meta-analysis was actually rather comprehensive and interesting. It's actually helpful. And we can see that barrier exists in every segment of the Hep C care cascade, inclusive of patient, the provider, and also the system. So many studies are actually focusing on the antibody testing and also linkage to care as what you can see here. But there's actually also some subdivision in terms of all this, the care of cascade there. So to ensure that Hep C eliminations is a successful program, all these elements must be taken care of. However, we always come revolving around the issues of the budget limitation. We have to actually plan our program very well and very carefully and see which component in the cascade of care is actually important for us to actually invest the money in and also the time. So as what you can see here, the integrated care coordination, and also patients' education are critical for success. And sometimes the DBS, the dry blood test system service, and also the POC testing could improve the HCV testing, and there's actually evidence actually lacking for finance incentive to the PV group. So this is a busy slide, but I try to actually simplify it for you. If let's say you can actually follow what is a component that's actually the significant, would actually ensure the success of your program is antibody testing, which must have a multiple component, care antibody, and also on-site swab collection sometimes, and also opt-out screening. And if let's say you look at the linkage of care, then the provider care system and also telehealth would actually have some impact. So there's many interventions that could be beneficial in each care cascade component, and the specific interventions are more efficient than the other. So what have I learned from this journey of the PV in Singapore, who's actually released from the drug rehabilitation center, going through the in-care, pre-release, after-care, and reintegration, through the Educate, Test, and Treat program, in which is actually at the reintegration of the inmate back to the society, when they are residing the halfway house. We started off the program back in 2022. Then after we have a launch, then we decided actually to do a validation test in the POCT to ensure that what we are going to actually upskill is actually really something reliable. Then along the process that we gather the correlation of effort from all the other halfway houses who's actually willing to actually, to look into this Hep C the problem in the PV group. So to summarize, what we are doing here is actually the ETT program have outreach for program participation, in which we actually managed to actually have a collaboration between the 5 major halfway houses in Singapore. And however, it's still at the opt-in testing at the moment. The Hep C testing, we evaluate the point of care testing using oral saliva for Hep C antibody, because we foresee that in case that we need to actually decentralize the model, then we hope that this oral saliva testing can be actually led by the halfway house personnel, which is actually non-medical. And if actually you rely on the finger prick, the services, because there's actually concerns of infection. So you probably need to actually allocate a healthcare personnel to actually go down to the halfway houses. So in Singapore, we have at least 10 to 15 halfway houses, big and small. So the question is actually how are you actually going to sustain it, and how are you going to actually do a periodical kind of testing? All this is actually important to be part of the consideration. So we also educate the educational brochure. I'll show you the few components example after this. To actually guide the PV group on their treatment and also disease treatment journey. And we also hope that actually it can be a peer guidance approach. And we are going to train the halfway houses personnel to actually guide the newcomer on this, Hep C elimination program. So we have an ETT care coordinator, in which they try to actually engage and then also facilitate the appointment and also the final application, linkage to care through telehealth, and also some participation on general practitioner and the treatment initiation, and with some product care coordination, in which I go into detail later, and also rely on the FIT4 pre-screening rather than only fibroscan screening, and also the finance incentive that we actually try to actually get the support for the medical cost on DA treatment. So the first question is actually whether the POCT using the saliva is actually comparable to the venous blood testing or the finger prick testing. So we went down to halfway houses every 2 weeks, then to recruit about 10 to 15 patients, and managed to actually come to the sample size of 210 patients, approximately 210. And we finally able to analyze 207, and the average age is actually 53 years old. And most of them are males, mostly is Chinese, and some of them are the residents, and some of them are the alumni. So we compare the blood tests, the performance to the saliva testing, and also the finger prick with the blood test. So this is what we found. So the saliva test, even though it's actually very conducive, but however, if you look at when we actually move from one halfway house to the other halfway houses, then there's actually some disparity between the performance of finger prick tests and also the saliva test. We decided to actually look at this in the further detail. It's actually because if you look at the sub-analysis of 103 patients, the first halfway house in which we have more control to actually ensure them to actually have 30 minutes of no food and also no drinks. And we are actually able to achieve 77.5% of the performance, which is actually a little bit lower than the reported literature rate, sometimes actually between 85 to 95%. So collectively, there's some significant differences between the finger prick and also the oral saliva tests, in which finger prick will give you 81% and 74% by the oral fluid. And the insight from here is actually for the other halfway houses, like halfway houses 2, 3, and 4, we actually all rely on this patient self-reporting. Whether you have fasted for 30 minutes, then we actually perform the test straight away because of the logistic issue. So there is some variation in the oral fluid and oral pathology, such as mucositis or the collection methods, which actually may impact the POC results. And apart from the choosing a right testing, we also have to actually look at what is actually, the way to actually go by the conventional pathway. In Singapore, to get a subsidiary pathway, you need to actually get a referral from a polyclinic and also a trust clinic. And after that, you get a referral to the hospital, the clinic, in which with some waiting time. So all this could take up to 12 weeks. So we actually collaborate with a trust GP, in which we have a POC test performance and which have verified the result through the telehealth, because a verification of a Hep C POC still need the healthcare personnel at the moment. And after that, if let's say tested positive, then on site the GP will refer to the hospital clinic, and this we managed to actually cut it down to about 2 weeks. So we also rely on the FIT4 because from the learning cycle, we noticed that to wait for the FibroScan to give us the results of the advanced fibrosis is actually too long for us. And then we noticed that the longer time of the waiting time, the more patients will fall out from the system. So we try to actually adopt the AASLD guidelines in terms of utilizing the FIT4 to actually screen through the those actually without the advanced fibrosis. And we coordinate for those actually at the indeterminate and also the advanced fibrosis stage to actually have a FibroScan confirmation later. But this doesn't impede the referral pathway to initiate the DAA. And as well, you can see here also, because we need to actually go through a lot of finance application in terms of the eligibility to get the subsidy from the government for the DAA. So that's why we also actually, partnered with the charity association to simplify the application process to get them to start the DAA, and we are able to manage to actually cut down the waiting time to about 6 weeks from the time with a POC positive. So there is some fine coordination in the integrated care in between the conventional pathway and also simplification pathway. So as what you can see here, if let's say it's a test positive at the background, the patients come to us at the first visit, we'll calculate the FIT4, we evaluate whether there's actually a need to actually treat the viremia. And if let's say there's actually a need then we actually will contact back to the Harvest House coordinator who actually will initiate the application to the charity fund for finance assistance. And this actually will take typically about 1 to 2 weeks. And after that, with approval that we from us, then there's actually a coordination between the clinician and also the pharmacist to get the medication ready. So with this, we have managed to actually reduce the overall waiting time of 22 weeks down to the waiting time about 5 to 6 weeks from here. So this is actually a summary of what we do. In terms of visit, there's actually at least 11 steps for the visit for the patient in terms of the activity to get the DAA, to get DAA, the treatment and also the SVR. However, with remodeling, we are actually able to actually slash down to about 4 visits if actually there's actually feasible through some integrated care, some collaboration, and also some telehealth technology. So as an example, the patient education by the peers, we hope that we already developed this brochure. And in this brochure, we have some program on the transport incentive. There's a peer support, elements inside. And we actually educate the halfway house personnel to actually understand the natural history so that they can disseminate the knowledge to the inmates. And also we tell them that this POCT performance, what is actually outcome from our evaluation in our ETT phase 1, the performance of the oral quick POC test. And after that, of course, it's not a perfect test. So there's actually some risk mitigation. If let's say they feel that really they are at risk, they want to know 100% for sure, then we still have the pathway for them to actually go to the trust clinic to actually have the proper test done. So I will also lastly want to highlight this role of a care coordinator and also befriender, because for this marginalized underserved group, they are very frightened, or they feel they're stigmatized to actually come to the hospital. They need to actually hold hand with a befriender or a care coordinator. And I have I'd like to have Larry Sogiago to come. He's actually have a Hep C infections before. He went through a journey. He understands about the experience and also the hurdles of to get a Hep C treatment done. So he's actually in the best place to actually to become a care coordinator and also befriender. So if I want to actually critically appraise the educate, test, and treat program, which is actually looks like that, we're actually planning to actually upscale, hopefully to get the blessing from the government, the policy through the help from the senior. We probably can actually, apply some of the knowledge that we learned from this ETT small model and see what we can do better. But as well, I can appraise here is actually on track on the antibody testing and the first part, and the linkage to care and also the treatment initiation. We still need to do a lot of other work. So in conclusion, simplification of a Hep C care cascade could enhance the uptake of the Hep C elimination program. And this is essential for cost saving, prevention of attrition in the care, and also sustainability of the program. So this could happen in the cascade of POC testing using OLAS level, care coordination, hospital navigation, finance reimbursement, application, clinic visit for the Hep C treatment journey. However, there's still some challenges in ETT program. It remains exemplified by the diagnosis performance of the test we choose in terms of the acceptability and also the practicability, and also the special needs of the undeserved group, and also the budget allocation for the treatment. Thank you very much.
Thank you very much. Please come and take a seat here. So we have maybe 10 or something minutes for discussions about they give a talk about how to improve HCV care cascade. And it is a little bit difficult to, if they found so positive, but it is difficult to link to care. So especially for the PWID person. So is there any questions or some comments or others?
Fantastic presentations of really model programs. For Grace, what struck me was just how well is testing going to get those patients into those quality care systems that you were speaking of? And are there any particular incentives for clinicians to order the test or test routinely, automated as part of electronic medical records, or if there are other strategies to improve testing? And then I'll stop there. I'll start with you, Grace, first.
Great, thanks, John. Yeah, I will say that at this moment we are making it a kind of like pilot program, because we have some close partnership with our like NGO social workers. So for some of the doctors who have the experience working together with the NGOs, they're more willing to either provide some fast track referral, as well. They are also more willing to screen more patients that they perceive they have risk factors. And very recently, we also trying to expand the screening to some psychiatric patients. We also have close partnership with psychiatrists, especially those who have special interest on managing patients with substance abuses. And we also kind of already started a couple of years ago that we advocate them to essentially screen all patients to their clinics or to their wards that those with risk factors of substance abuse. They also screen more Hep C. So that's why there are also more referral from that part. But I have to say that we still have a lot of podcasts not well screened. In fact, we wish to further expand to like probably all patients who have mental problems, either to the psychiatric clinics or hospital, but not every psychiatrist will share the same view. I think those with experience in substance abuse patient would be more willing, but for general psychiatric diseases, they are less willing. So I think probably we still need to have a lot of like actions or campaign to move forward to let them know their risk factors as well. Their risk profile is a bit higher than the general population. Then we can try to expand the screening program. Yeah, thank you.
Yeah. I mean, to that point, I wonder if perhaps you do this just to give feedback to that psychiatrist that, their referral ended in a cure for their patient, et cetera. And maybe that continues to motivate.
That's very helpful. In fact, we have this feedback, either the patient have come and have successfully treated, or the other end would be some patient who didn't show up. We also feedback to the psychiatrist. And for those who defaulted, we keep asking the psychiatric nurses to keep chasing them back to hopefully link them to care on someday. Yeah, that's very, very helpful. Thank you.
Dr. Chow, and maybe Grace also, I know in the United States, I asked this for Junko yesterday for Japan. There's a fairly high percentage of patients who get diagnosed but then don't get treated. And sometimes they refuse treatment or feel like it's not that important, or just because of the way the system is set up, they fall out of care. And So I was just wanted to get the experience from Singapore and then from Hong Kong about what's that level of acceptance after that diagnosis happens. Thank you.
Check overs, yeah. So the level of acceptance of Hep C, I mean, Prof, I have to actually say this is actually because if you actually diagnose them very early, they have no symptoms. They have others priorities in life. They are in the integration back to the society. And the way I look at it is actually, if let's say education on Hep C natural history is just not enough. You really need to actually engage with somebody from, I mean, the who actually went through. That's why my care coordinator is actually inside there. Explain why they should get it treated. And it have to actually come down to the actually peer support level. We did have a survey, and no, I think about 60% of them would actually accept the talk to the, I mean, with peers rather than with a healthcare personnel. We went through 2 years to develop this program. It's very bumpy. So along the way, I think we noticed that there's actually a high rate of attrition. And if let's say they perceive this as so important, and they will actually come forward to receive the treatment and also to get the consultation. And that is also the social aspect, which is actually very difficult, in which, like, for example, there are actually frontier, as what I presented before, that's actually is a front desk kind of work. And then they cannot leave their workstation so easily. Then you need to show them the notification to the employer. And there's actually some sensitivity. Then the employer asks them where are you going and everything. So it's actually rather tricky. But I should say that I think with the integrated care and also with the peer support, we can go there. We just need to show these models actually working. We need some more blessing from the political will, seniors to actually talk to the government to actually, give us more budget to actually upskill. Yeah. Thank you.
Thanks. Just a quick question. So
Okay.
very
Thank you very
nice
much.
and
Yeah.
inspiring presentations. I just wanted to get your perspectives on the emerging opportunity for the use of long actings. And you may be aware that particularly focused on GP, that it's probably a couple of years away, but the potential for a long acting, it could be 1 injection, it could be 2. So how would you see this as being a game changer or not for your patient population? And I think it's particularly relevant to the disadvantaged, the homeless, the PWID who have difficulty coming back and adhering. Thanks.
Thank you so much. I think this is definitely would be something very helpful for a very special group of patients, which is particularly challenging at this moment. I would say that, like, also feedback a little bit to the previous questions, that the treatment uptake, the willingness to be treated at this moment is already quite high. I would say the current day regimens already cover probably more than 90 or 95% of patients. But I fully agree, some particularly challenging patients. I also come across some patients after being diagnosed to have active viremia, they still refuse to come back after multiple courses. So I think that probably because of their social issues, some would care about their work, their food, more than their chronic hepatitis C. So I think for those like homeless people, that you probably only can see them once in their whole life. I think this kind of long-acting agent would be very helpful to further push up the treatment uptake way. Yeah, thank you.
Okay.
Okay, thank you very much for a nice presentation. My name is Tatsuya Kanto from Japan. And I have a question to Yaku, and the Singapore system. Sorry for mispronunciation of your name, but anyway, and I'm very impressed about the simplified method. That is a key strategy for enhancing the cascade care. And I think you explained the other part about the care coordinators in your country. but because in Japan, we have a similar education system for medical staff, hepatitis care coordinators to support patients and of course, patient families to encourage and test and treat. And in your slide, I could have found that some kind of advice or support is reimbursed. Am I right? And because in Japan, working by the hepatitis care coordinators is not reimbursed because systematically. So I think that is a really important issue to encourage such kind of medical staff to get into the supporting activities. And of course, they're acknowledged about how important their work is. So I want to learn a little bit more about how and how have you accomplished in your country the reimbursement system for supporters?
Thank you for your excellent question. We have a struggle, and the struggle is still ongoing. The reimbursement, we call it as co-payment. So for out of 100% of the DAA cost, there's no generic in Singapore yet. So most of this peer group will get 75% of the subsidy, and that for the leftover 25% is actually that must bear by the peer group. So the 25% is actually 1.8K Sing dollar at least. So this is a big sum to them. So for that, right? I think there's actually a pathway for the medical assistance fund approval, in which and also the Medifund approval, in which the patients actually need to actually submit document, and that document is actually per household document. Means that whoever actually sharing the same IC of your, under the same household, they need to provide their salary slip, and then during the interview and or something. This is actually where the problem is. It's actually because of the kind of background, the high risk background and the family dynamic, we cannot actually ensure that all the family members actually that supportive, and that's actually one of the critical area that has actually caused the breakage in the linkage to care. So we have to actually move this forward. So we get we actually outreach to the charity organization, and which is actually very willing to help us. And that's actually what I can actually demonstrate inside the slide, that if let's say there's actually finance assistance that and on that path, we can actually very shorten it. And the finance application documents requirement is actually not that stringent as compared to the interview by the social worker. And we actually will actually also explore your habits of smoking. Smoking, and also why do you do you have why do you have money for smoking and no money actually to save for this DAA? So we are still in the process of discussion. Because after the submission of collation of a document, you still need to actually wait for the meeting, which is actually at a monthly or 2-monthly basis. So this is actually explain why there's actually a wait. And then during the wait is actually dangerous because they will fall out. Yeah. So so that's why the care coordinator, if they have a support, and then because we are at the medical site, sorry, taking some time. We are at the medical site, and they are actually at the social side, then they'll be actually unable to actually see. The care coordinator is actually coming from the background that they know their family better than us. So that's why they are actually ambassador for us to actually to talk to the family, to collect the document, and to actually make sure that whatever is actually appropriate is actually submitted on time. Yeah. So this is actually what we're working towards.
Okay. So what kind of occupational background do they have, the care coordinators? The most of the nurses or public health nurses, occupational background for the care coordinators in your country?
Oh, so for these care coordinators, actually from the halfway house, it's not a healthcare personnel.
Okay.
Yeah.
All right. Thank you.
Okay,
Yeah.
please.
I'm Dr. Chen from Taiwan. I have a question to Grace. I thank you very much for your wonderful presentation. As you know, if we want to reach the WHO HCV elimination, the major barrier is try to find out those HCV infected patients lost unawareness. So do you think we should do the nationwide HCV screen program to find out those unawareness of HCV infection?
Great, Professor Chen. I think, first of all, I would like to congratulate Taiwan has been doing a great job in terms of HCV screening and engagement management. I know many doctors in Taiwan, they also have some different kind of screening. They outreach to some relatively rural area, or I also come across some like they see the chance of patient come to the diabetic clinics. They also would do the automated screening, which I would say that at least in Hong Kong, because our prevalence is 0.3% for chronic hepatitis C. So I don't think our government will agree to do really a universal screening for everyone. Probably not. But I think we still have a few podcasts that we haven't have a very systematic screening. I would say that patients with mental illnesses or patients with even, I think diabetics is something that a very wise move because they are coming back for complication screening anyway. So we just add one more test for them, as well as some of the like very underprivileged people. In fact, those we know that their preference will be much higher. Like for example, homeless people, usually more than 10 to 20% of preference. So I think probably at least in Hong Kong, our government would prefer to focus their resources there. But I think can stepwise, and we can definitely go along with the existing data. Perhaps if the known preference is above certain threshold, we can definitely screen that population. Yeah, thank you.
Yeah, thank you. I also have a question to Dr. Zhao. Because point of care HCV testing is more cheaper by finger stick than the using saliva, but you choose saliva as a point of
or
test.
saliva. Yeah.
Saliva, point of care. So why do you
Yeah.
why don't you choose the point of care testing by finger stick?
Okay, it have to depends on which type of finger prick test, which brand are we using. So in our project we use Oral Quick. We actually really want to actually see the saliva. The things about saliva test is actually you really have to actually have experience to hold the stick and ask the patient to do in front of you, and following through the procedure. Then you can actually really appreciate how simple it is, and it is just fall short of their performance of sensitivity, and it's actually antibody test. I do agree that there's a limitation, but however, the saliva test is actually, they're so easy until, even the WHO is actually promoting self-testing. So there's actually no reason why the halfway houses, the staff won't be able to actually test, using this. So at the periodical basis to actually check for the prevalence of the antibody. So I think saliva test is very inviting. We have a survey of feedback to say that if let's say compare the finger prick, venous blood, and also the saliva, which one you would prefer? If let's say somebody performed to you, then you can see my slides actually is quite heterogeneous. But when we actually revert, the question is actually if you want to actually perform yourself, which one will you prefer? Then everybody will choose the saliva test. Yeah.
Thank you.
Okay, so thank you very much for great discussions. So the presenters bring a fast track program to improve linkage of care. So we have to consider about this. Thank you very much. Thank you very much. So we will take a break, and John suggests
we'd love to get a photo of everyone as we traditionally do here at these forums. So before we break, if everybody could come forward for a quick photo, I would greatly appreciate it.
Good afternoon, ladies and gentlemen. My dear friend, Dr. John Wo, and dear colleagues, it's my great honor to moderate this session. And for the session 3, the title is In General Population HCV Elimination Initiative in Asia Pacific regions. So I'm Minong Yu from Kaohsiung Medical University, and also the National Sun Yat-sen University, Kaohsiung at Taiwan. Next slide, please. Next slide, please. Okay, here. Okay. Next slide, please. Okay, this is the figure of the disease burden of chronic HCV by living infections. It's estimated around 58 million people are living with the virus in 2019. And of this population, around 10 million people are living in the Western Pacific region, and another 10 million people living in Southeast Asia. Next slide, please. So the WHO set the goal of HCV elimination by 2030. But if you see this figure, you can see the expected HCV incidence and mortality trends from new action implemented under the strategy is denoted by the dotted lines, versus no new action denoted by the dotted lines from 2020 to 2030. If there are no any action implemented, the new infection people will maintain at 1.4 million per year, and the HCV rate days will maintain at around 250,000 days per year. So only implemented the new action, we can have the hope to reach the WHO goal and decrease the new HCV infection to 350,000 and decrease the HCV related days to less than 140,000. Next slide, please. So in this session, we are happy to have three speech from Taiwan, Japan, and Korea, and also a special lecture from Professor Omada. So right now, I would like to introduce the first speaker, Professor Wu Chonghui from Kaohsiung Chang'an Memorial Hospital, who will share the screening and testing strategy for the people living with diabetes. So let's welcome Professor Hu.
Thank you. Thank you, Professor Yu, for your kind introduction. Today, I'm going to talk about the elimination activity in persons with diabetes. It is a learning from Zhanghua integrated program to start hepatitis C infection. We call that as CHIP-C. So Taiwan's government has conducted the policy direction, core strategy, and universal DA reimbursement since 2019. And we announced national elimination by the end of 2025. Zhanghua County was located in the central part of Taiwan. The Public Health Bureau is in charge of 27 local health centers in different townships. And the Bureau have conducted CHIP-C program to follow up the national policy. By the previous experience of screening more than 123 participants in the county, the prevalence of HCV infection was 3.25% in general population. In addition to the high-risk populations, such as methadone treatment, HIV patients, prisoners, dialysis patients, there are also moderate risk populations, such as pre-ESRD, CKD patients, diabetes, and cardiovascular disease. Screening of these populations for HCV is very cost-effective because they belong to large volume populations. So the CHIP-C means a big chip containing many small chips, including different programs, institutions. So we have to do collaborative care with endocrinologists, nephrologists, GP, psychiatry, and infectious disease doctors. Before CHIP-C, we have conducted an age-period cohort model according to the prevalence of different townships in the county. we would like to estimate the exact number we have to treat in the program. According to the positive HCV RNA with 70% positive or 80% positive. So in the county, as you can see, the prevalence of HCV infection was much higher in the southwest area, rural area, when compared the northeastern area, urban area. However, most of the medical facilities were located in these areas. So in the rural area, there is a shortage of medical facilities like gastroenterology clinic or hospitals. But there is local health center in each townships in these areas. So they can become the basis to care HCV in community. So in the county, Changhua County have well-established diabetes shared care program since 2004. There is Diabetes Health Promotion Institute in each township with complete list of diabetes patients. So for diabetes population HCV care, we combine HCV and diabetic care together to facilitate the screening, diagnosis, referral, treatment during patient regular visit in their diabetic clinic. So by utilizing the diabetes care system for HCV elimination, here, there have been more than 10,000 diabetes patients in 27 local clinics in the community. So by 6-step implantation, such as simplified process, HCV plus diabetes testing, and the streamlined referral, we can easily reach the micro-elimination of diabetes population in this program. You can see that there is significant improvement after the implementation of the program. It means there will be no extra patient visit, no blood draw twice, and no duplicate procedure and the paperwork. We further extend the model to all diabetic patients in all institutes and hospitals in the county. There is a big volume of target population, more than 66,000 patients. So as you can see, there are still a very high coverage of HCV testing, linked to care RNA testing, and the coverage of treatment. After 5 years of work of CHIP-C, as you can see, there are nearly 5,000 participants have been screened for HCV. And mostly the older people aged more than 50 years old. The HCV RNA testing is 76% with positive rate of 76%. Totally, there have been more than 14,000 patients have been treated. The coverage of treatment reached 90%. So in the left figure, you can see that by the CHIP-C, a county-wide HCV elimination model has been achieved based on the original estimate with 70% positive for viremia. However, the exact viremia is right now 76%. And there are still 4 townships left uneliminated. We had to do the further work on these townships. After the successful model of CHIP-C, we further replicate the model, especially diabetes elimination model, into my hospital in 2021, Kaohsiung Chang'an Memorial Hospital, and extended to other branch of Chang'an Memorial Hospital in 2022-2023, which was led by Deputy Professor Jianlong Ran. So this is also a big volume target. You can see that more than 49,000 diabetes patients with a very high HCV testing, 85% are linked to care, and treatment coverage more than 92%. After the elimination model in hospital, you can see that there is significant improvement of care cascade outcome before and after initiation of HCV elimination program, such as antibody testing, RNA linked care, and treatment coverage. In the right table, you can also see there is significant improvement or all liver profiles after treatment, such as APRI and FIFO index. The SVR rate of diabetic population in hospital by DAA was 97.8%, which was similar to other special population. So ladies and gentlemen, in conclusion, diabetes is one of the important and big population, about 2 times of prevalence of general population. A novel community and hospital-based models were successfully implanted by combining the diabetes and the HCV care work. There is also a significant achievement of county-wide elimination from CHIP-C by collaboration between different disciplines. It is very important for HCV elimination in any other population. I thank you for your attention.
Thank you very much, Professor Hu. I think it's a great model in the micro elimination based on the precision strategy. So because we will have a panel discussion of the, at the end of this session. So here I would like to invite the second speakers, Professor Tadashi Ikegami from Tokyo Medical University, Ibaraki Medical Center, Japan, to share the HCV screening strategy for the general population in Japan. So, ladies and gentlemen, let's welcome Professor Ikegami.
Good afternoon, everyone. Thank you, Dr. Yu, for your kind introduction. And also, I greatly appreciate to Dr. Ward and CGHE members and Professor Shina, president of this APASL meeting, for organizing this forum and giving me this opportunity. This disclosure. First, I will briefly mention the history of Hep C in Japan. It is assumed that most of the elderly Hep C patients in Japan were infected by transfusion of contaminated blood or blood products under the blood selling system. The blood selling system was abolished in 1990, and the using of disposable syringes and needles at medical facilities became standard around 1988. This suggests that infection may have spread endemic in the region, mainly through the injection performed at the medical facilities before that time. After the cloning of HCV in 1989, the blood donor tests were studied, and the post-transfusion infection decreased dramatically and then disappeared. The infection rate among first-time blood donor has reduced on the current level of about 0.13%, which indicate the decline of HCV prevalence among in general population in Japan. The current Japanese policy against viral hepatitis was established based on the law called the Basic Act on Hepatitis Measure, issued in 2009. Under this law, the nationwide system for prevention, screening, and treatment has been formed. This slide shows that the patient with viral hepatitis can receive a generous lifelong support structured based on this law. Today's talk focuses on the screening strategy of Hep C in Japan. We have a lot of opportunity to do that. Under the Health Promotion Act, the milestone checkups, municipalities offer the milestone checkups for individuals who have never undergone screening at the age of the 40s and every 5 years after that. Additional screening is also available for those out of milestone ages with abnormal liver function and history of extensive surgical procedure or heavy bleeding. Each public health center offers a hepatitis virus test free of charge and anonymously as a part of a countermeasure project for specific infectious diseases. The pregnant women are screened in prenatal checkups. In addition, the testing is routinely performed in the medical institutions as an infection check before surgery or invasive procedure. Milestone checkups were started as a part of the geriatric healthcare program in 2002. Sorry about the layout of the graph. During 5 years of screening, based on this program, between 2002 and 2006, about 9 million people were tested and 100,000 HCV positive cases were discovered. From 2008, the Health Promotion Service took over the program. Additionally, in the same year, a specific infectious disease testing service were added to widen the availability of the test. From 2010 to 2017, about 10 million people were tested, and the HCV prevalence, positive rate in general, the tested person is 0.33% in 2017. So what percentage of the general population has already been tested in Japan for Hep C? Professor Tanaka's group has conducted several nationwide surveys. In these surveys, self-administered anonymous questionnaires were sent to the randomly selected residents. The respondent with a history of blood donation, childbirth, or surgery, but no self-awareness of the testing defined as unrecognized testing. The latest survey was conducted in 2020, when questionnaire was sent to 20,000 persons, and 44% responded. The testing rate, including unrecognized testing, increased by more than 10% from the initial survey conducted in 2011. However, the research group realized that the not tested group shown here might not include the person of a previous public test recipient unaware of the test and without a history of blood donation, childbirth, or surgery. So they conducted a different study for persons who have a hepatitis virus testing during health checkup. This study revealed that many people forgot the testing history in the public health checkups. Then, adjusting the nationwide survey result with the forget the public test proportion ratio, this one, the HCV testing rate among the general population can be estimated as 76% currently. This presentation will be given by Professor Sugiyama, one of the members of the group of Professor Tanaka's in this APASL meeting. The survivable patient who recently treated with DAA show that 70% recognize they were first informed about the infection in medical institutions, while the lower percentage said it was noted by public testing. Japanese healthcare providers still almost routinely perform the hepatitis virus testing as an infection check before the surgery or invasive procedures. Our facilities data show that department with many history had many tests, and the proportion of HCV antibody positive person was also high. The most patient in specialist clinics have already been treated, so the linking the patient found by these non-specialists to care is essential to reaching their elimination goal of treatment. The preoperative tests are excellent opportunity to reaching to discover the newly diagnosed patient, as well as the person's reminder of the persons of a previous test. In 2018, the Ministry of Health, Labor and Welfare requested that each medical institution to notify the patient of the hepatitis virus test result when it was performed as a part of pre-operative checkups. To address this request, we have integrated the test result notification method into our hospital's admission management system. The pre-operative tests were ordered in our clinic before patient hospitalization. So the blood sampling and testing are done in laboratory, and the lab tech sorts the test result, and the positive results are sent to the hepatitis medical coordinator and as well as attending physician. Coordinator asks the attending physician to disclose the test result to the patient during hospitalization. Negative results are sent to admission and discharge preparation center, a station guided hospitalization, and gather the information for area discharge. After admission to the patient will notify the test result in orally and in document. Negative result was notified by inpatient wards such as nurses, and positive result was informed by attending physician and medical coordinator. If patient were not treated or not followed, the consultation to a specialist is recommended. If one patient agreed the consultation, the doctors refer the patient to a specialist. In this system, we can efficiently connect the patient with active infection to care. Lastly, I'd like to introduce the current treatment status in Ibaraki Prefecture where I work. In this graph, the purple line shows that the estimated number of HCV positive persons by birth year. Well, it is based on the public testing-led data. The blue line also indicates the number of patients who use the subsidy program for treatment. Since most patients utilize the subsidy program for the treatment, it is very helpful to grasp the total number of the patients treated. The treatment for volume patient born in 1940 to 1960s seems to be satisfactory, so we are getting closer to goal, we believe. Summary, in Japan, the basic act on hepatitis measures was issued in 2009, following a nationwide public health checkup started in 2002. Test rate is likely achieved to the elimination goal, and easier access to medical facilities in Japan is advantageous. The key to overcoming this situation is the participation of core medical staff and the collaboration with non-specialist doctors and immediate action after getting the test result. And also, I want to notice that the prevalence of active HCV infection in the general population in Japan is declined. So probably installment of a trackable recording system for testing and treatment history should be considered like Taiwan. Thank you very much for your attention.
Thank you very much, Professor Ikekan. So we will have a panel discussion later. So let's move to the third speech by Professor Jung-Gi Cho from the Asan Medical University of Ulsan College of Medicine. He will share the HCV nation screening and elimination strategy in Korea. So ladies and gentlemen, please join me to welcome Professor Choi.
Professor Yu, thank you for the kind introduction, and I'd like to express my gratitude for the organizing committee to give me this great opportunity to present HCV national screening and elimination strategies in Korea. I'd like to start with this graph indicating where we are now in the journey of the HCV eliminations. When we look at the Korean data, it looks pretty fine. I think we've already achieved the decreasing mortality, and then treatment rate has been already achieved. However, the problem lies on the underdiagnosis, and probably we are not detecting new cases as we expected. So this is basically the fact sheet which is published almost 3 years ago in Korea, supported by the KASL, Korean Association for the Study of the Liver. This fact sheet indicates that we have almost 8,810 new incident HCV cases across the country. Among them, 78.2% of these patients visited for HCV disease code at least 2 times in a year, visit the hospital. And among these patients, only 74% are treated with the DAA. This refers of the almost 9,000 new infection patients, only 58% were treated, which is a little bit lower than our target. This is my personal opinion. I think we may need different strategy and approaches according to the different levels. I'd like to summarize 3 levels. It could be national level and population level or hospital level, because I think these levels may have a different targets and different strategy. The first one I'd like to introduce is the national level. For national level, the target would be, of course, the government, and then strategy should be in Korea. We are trying to adopt HCV antibody testing into the mass health screening examinations. So thanks to our national health insurance system, we have very good national general health screening program in Korea, which is fully funded by our government. For adults, every other years, they have lots of tests free, including some blood work and anthropometric measurements, some questionnaire, and chest X-ray and bone BMD. Our goal is we'd like to put anti-HCV testing into this mass general health screening program as one of the blood tests, because we believe this would be very effective, because the participation rate of this mass health screening program is about almost 80%. So actually, we've done already pilot program for this mass screening. 3 years ago, almost 4 years ago, the eligible patients for this pilot program was those who were born in 1964. At that time, patients were 55 years old. Of the eligible patients, 133,000 Korean people, almost 80% participated in this pilot program. They got blood draw and they were tested to the anti-HCV. 0.75% were positive for the anti-HCV, And among them, 70% were treated with the DAA. An interesting thing was that of the participants, only 6% of Korean people got HCV testing before. That means the rest of the 95%, they never get the HCV testing in their lifetime. So based on these pilot programs, we've done the cost-effective analysis, which shows if the anti-HCV positivity prevalence is more than 0.2%, mass general screening for the general population could be cost-effective. And then, as I mentioned earlier, in Korea, we are estimating anti-HCV positivity prevalence would be almost 0.8%. In terms of the cost effectiveness for the HCV universal screening, we've already published it many times. HCV testing would be cost effective and the ICER is quite affordable, but always the key is in the government. We try to launch this HCV screening program, but we are still waiting for the call from the government. I don't like this icon, but so for next level, I'd like to introduce the population level. It could be targeting for the Korean general people, and the effective strategy, I think we have to increase the awareness of the HCV infection. So for this, our CASL made many efforts. First one is we provide many broadcasting into the general media using the campaigns, almost 53 times. And then he is the former president of the CASL. So for about 30 seconds, he explained why the HCV is so important. And also HCV is curable these days. The other action we are doing right now is we try to collaborate with other healthcare workers. For example, with dentists, with a physician who are working in the private hospital. Our CASL provides flyers, pamphlets, and posters. They can be hanged or they can be attached on the wall in their clinic, and to let the patients who visit their hospital to know more about the HCV infection. The last one is hospital level. Probably the target would be hospital administrative, and the strategy would be increasing the diagnosis and the treatment rate. And we published almost 3 years ago about what happened in the HCV care cascade in a tertiary hospital where I'm working at right now for the past 20 years. And unfortunately, for the past 20 years, there's no big advancement in every step. In our report, HCV RNA testing rate was almost 70%, and unfortunately, the treatment rate was very disappointing, which is about just 35% on average. So I'd like to briefly introduce about the real C model, which is just started two years ago in our hospital. This is the scheme of the real C model. If a patient had anti-HCV positivity blood work, and then they do not need additional blood work. So our laboratory department members, they order the HCV RNA testing, and then it will just directly report it without additional blood work, which is the reflex testing. And then if the HCV RNA test comes back positive, and then this news will be automatically notified to the physician who ordered the test. And also it will be automatically registered in critical value reporting system, CVR, in our hospital. And if we got the CVR, and then we have to respond within 2 weeks about what I have done for this. So we compared before a period before the real C model, and then we started from the real C model in patients only, and then it was quite successful. Then we expanded our real C model into our patients. So basically, all patients who visit our hospital, they are eligible for this real C model. So this is the result. The pre-real C model, the HCV RNA testing rate was 51%, and it increased to 66%, and finally it goes up to the 95% of the HCV RNA testing. And more encouraging thing is this one, I think. When we finished the complete real C model, every department has at least more than 90% of the HCV RNA testing. The remarkable stuff is before the model, the surgery part and some non-liver surgery and internal medicine, non-gastroenterology, their rate was quite low. And also after adoption of the real C model, GI referral rate increased and the treatment rate was achieved around 90%. And in terms of the key matrices from the anti-HCV positivity to HCV RNA testing, it was previously 45 days and it goes down to 2 days, which because of the reflex testing. Thank you.
Thank you very much, Professor Choi. Please have a rest. So let's move to the last talk of this session. We are honored to invite Professor Masao Omada. He's the current president of Yamanashi Central and Kita Hospital and also Professor Emeritus at the University of Tokyo. He's going to share the DA-induced paradigm shift in HCV high endemic area of Japan. So, ladies and gentlemen, let's welcome Professor Omada.
Thank you very much. I will touch upon a little on HCV in hospitals. There is no disclosures. Well, I was in the University of Tokyo for 17 years. The governor asked me to move to the Yamanashi, which is surrounded by the mountains, especially by the Mount Fuji. And then it's west of Tokyo. And then I graduated medical school, Chiba University. Therefore, for the last 53 years as a physician, I'm going back and forth in east and west. And then after moving to the Yamanashi Central Hospital, what's happening in there is I moved 14 years ago. Then if you take a look at the incidence of hepatocellular carcinoma in Japan, there is some deviations. Western part of Japan, you have a very high incidence of the hepatocellular carcinoma, maybe due to both B and C. But if you go to the eastern part, including Chiba and Tokyo, there is some area which has a high endemic area. That's Yamanashi. The reason is rather simple because we had the Mount Fuji, but also we have Mount Fuji now. Sorry, but we had Schistosomiasis japonica there, just like in the Kyushu Islands. Then that's the reason why it's endemic. It's not because of Schistosomiasis japonica, but the treatment by intravenous Stivner is used after the World War II. So I moved there 14 years ago. And how do we tackle before we go to the discovery of the virus? When I was in Chiba University, I started collecting all the blood samples for the transfused one, and then watch the transaminases. And this is the cases of 14 cases. 80% are showing the continuous fluctuation. We started maybe around 1980. Then interferon was started for HB 1978. So we gave this interferon. In fact, J. Hoffner gave the interferons for the non-A, non-B chronic hepatitis and showing the transaminase normalizations. So I gave this to the post-transfusion acute hepatitis to prevent the future fluctuation of the transaminases. But during the meantime, microfalton found the cDNA. Therefore, we set up a cDNA PCR assays, and then we are collecting the prospective data. And it turned out it coincides with the abnormal normal transaminases, disappearance or persistence of the virus. So this is the very beginning. Then if you go to Japan, and we have 120 million population, Yamanashi is a small county or province, only 0.8 million, 800K. And our hospital established 150 years ago, oldest in Japan. And we have the 0.589 million or 589K medical records in the last 50 years. So population there is only a matter of the 80 million or 0.8 million or 800K. But in 50 years, every year maybe people are dying 7,000 or to 9,000. So altogether, maybe denominator can be 800K plus 500K. Then we have 589 case medical records, which is covering almost 45% of the area. In other words, the patient who come to us is from the local area, 97.3%. So among this cohort, what we have done? Well, we are aiming at total elimination near zero programs in Yamanashi. In fact, this is just started. In other words, people came and then give that presentation. So I just collected the data, in fact, in reality. And then, but there is a barriers. Not everybody tested. And even though HCV positive, not everybody tested the HCV RNA. So I explore that. I'm in the position to make things in the hospital. So I asked the people that questions, erase the questions. And then during those days, all registers, the one who has a medical records is 588,000 cases. Then this is the tested cases of HCV antibodies from 2001 to 2002. In fact, 2001 is a data collection of previous 30 years. But as you see, it's obvious. Used to be like 20% testing for all the patients who is coming to the hospital. But nowadays, maybe 40%. But it seems like a little bit down nowadays. So this is a record in 50 years. Then if it's positive, how many are tested? Among those 119K, AB positive rate was 3.5% in average, from 4.8 to 1.6%. Then RNA testing rate was among those AB positive from 46.4 to 20.6%. So it's a matter of 32.9%. So these are the two barrier figures. And in fact, among those AB positive cases, how much newcomers are positive RNA? It's very high still. Average is 64.9%. So if we go all the way to the testing, then you may find that 2/3 are positive for RNA. So among these barriers we tested, AB tested repeat 20.3%. RNA positive tested 32.9%. Therefore, naturally, we only find 896 patients. But if you do 100% testing, and it might be possible, then they may be just on calculations, 13,379, 14.9 times. But this is including 50 years records. So how about going back to the recent years? 109K came to the ICH, AB tested 36.2%, RNA tested 28%, 5%. So it turned out among those 9 years since DAA started, 149 new cases discovered. But if you do that, and maybe pharmaceutical industry is interested in this particular figures, 9.7%, times 9.7. So in all time, more than 10%. But even the last 9 years, it will be 9 times we could have found. So naturally, what department is doing these kind of things? So therefore, I checked who tested or not tested among the department. And it's obvious. Well, gastroenterology is okay so far. But if you go to the emergencies, the majority are not tested for RNA. I think it's quite reasonable because they have to save their life. So by this data, how do you go? I mean, we got to think about the cost effectiveness and everything. But anyhow, since I got this data, so maybe from April 1st, I may do something on my hospital. But anyhow, summarize by calculating the evidence of the infection by RNA levels from 2001 to 2007, 30 years time, 2.91%, and then 2.52%, 7 years, and then for the recent 9 years, 1.3%. So whether do you call this accomplishment or not, I'm not really sure about, but if we are aiming zero strategies, maybe this is on the halfway. But anyhow, I repeat, our area is a very much surrounded mountains, beautiful Mount Fuji, but also people communicate not much from outside. So it's very nice to conduct and continue epidemiological studies. And then as I said, 40% of the residents have our IDs because we are the general center hospitals and all the choppers and all the emergency ambulance came to our hospital. So this is what I saw in the last 14 hours. I left the University of Tokyo. So I acknowledge all those things. This is the Chiba era about Dr. Okuda, and then Kato sensei is not here, but it's also Kato sensei is not here either. This is a 17 years Tokyo University. And then now these are my younger colleagues. Thank you very much.
Thank you very much, Professor Omada, for the comprehensive sharing. So let's move to the panel discussion. May I invite all of the four speakers on the stage? And also, may I invite Dr. Jung Ho, Dr. Jung Wo? Maybe you can join me. Okay. Okay, any comment or question from the audience? Okay, please.
Thank you. Thank you very much to all the speakers. If I may just begin with a historical question and to Dr. Amata. And I was very interested in one of your slides, your first slides, talking about schistosomiasis, I guess in the late 40s, early 50s in that particular region of Japan, and that the treatment, I assume with praziquantel, or maybe it was something different that contributed to the spread. And I've been very involved with the Hep C response in Egypt. And of course, that was very much pinpointed to the schistosomiasis elimination campaign during the sort of the 50s and 60s. So my question was, what other examples of schistosomiasis? Because this is the first time I'd heard that Japan, that was probably one of the earliest contributors. And then it was the lack of the diagnostic test for screen blood. But could you just elaborate a little bit more? Because it is an interesting historical observation.
Yes, that's a pretty good question because majority are transfusions, obviously, and not many drug users. But then about psoriasis, it's because of Stivnal. That's the name of drugs. You got to shoot into the veins. That's why it's spread it. But the majority are transfusion in the hospitals. That's number one. Japanese would do some drug use to activate you, but not many. So that I would say 90% due to the medical practice, and then drug shooting maybe 5%. So Mansoni maybe the rest, in particular that area. That's my comment.
And when was schistosomiasis eliminated?
Small, but significant in those days. But after that, majority, well, because otherwise you can explain the things in the western part of Japan.
Thank you.
Okay, please.
Yeah, Dr. Choi, I'm intrigued by the data where you're able to line up all of these 55-year-olds and test everyone. I mean, that's a heroic and very important effort. Now, were you able to ascertain when these people might have potentially been infected, those that were positive, and any that might have had ongoing risk behaviors for HCV acquisition or transmission?
You know, I said 50 years back, and you may ask how come you can do that before the discovery of the HCV, because the big discovery was 1989. So, but fortunately enough, they come to our hospitals, repeaters. So they come, even the first visit is 50 years ago. If they are the age 20, they might age 70 when they came today. So we test it. And the majority, as I said, is a transfusion. Because in Chiba area days, I did so many blood sampling tips of the blood. And then I would say, normal baseline transaminase, if you got a transfusion, 10% show the fluctuations. That's why motivated me to study by interference to stop fluctuation. Because you remember that J. Hoffner is the one who put a paper in New England Journal about normalization of ALT by interference in cases only 17 or 18 cases. But I thought fluctuation prevented. That may indicate the virus disappearance. But those days, there is no way. But Michael Houghton show us DNA fragments, cDNA fragments. So we set up, we have a laboratory. So we are able to make our own. And then because follow-up length is 5 years, so during the time we had the blood sampled. So we tested. And then that's concordant with the disappearance of virus. That's the very, very beginning. I'm not that young anymore, you know that.
Any question or comment from the audience? Okay, maybe I have a question for the professor from the 3 countries. I think the national health insurance system is quite similar among the 3 countries. Though. We also have the nationwide insurance system covered by the governments, and I think the coverage rate is maybe 98% more in all of the 3 countries. So currently, it maybe have no barrier in the treatment rates and also referral treatments. So how about the strategy to increase the screening? I mean, does the national health insurance allow the universal screening, at least for the hospital-based population? May I have the opinion from the 3 speakers for Taiwan, Japan, and Korea?
Yeah, since the reimbursement and diagnosis is universal, so there will be someone that undiagnosed or treated. And in our model in Changhua County, the most available is the public authority, as well as the basic local health center in community. So that's where I have to find out the patients who was diagnosed or was not treated. And we have to find someone maybe who have been previous antibody positive, but not into care of RNA testing. And we rely on the basic community local health center and public health bureau very much. I think it is the most helpful in our model. Thank you.
Okay, in Japan, in terms of public testing, the whole money was covered by the government. Well, as a copay things is also included, but so mainly the financial support was provided from the government. And the problem is well, I mentioned in my presentation the workplace examination, because due to some private information matter, it is very difficult to grasp the whole situation, what happened in the workplace in Japan. So younger people tend to go to occupational examination, but it is not including hepatitis virus test. So probably, so we have to track on that. But otherwise, well, Japanese surveillance system is well covered by governmental support.
I think even though we tried many times to persuade our government to put HCV testing into the mass general screening program in Korea, I think the government position is that the HCV prevalence in Korea is quite low. And even though we keep saying if we just remove the HCV infection at earlier stages, it can save more money. If the patients are left untreated, government will spend more money to treat the HCC patients and liver cirrhosis patients. But usually the government try to save more money. They do not want to get more taxes from the general people. And then they want to see more, they want to some achievement in an earlier period. They usually do not think about what will happen in the long run. And also the other issue, this is my personal opinion, is the other issue is the regime and the government after the election. Usually they rapidly change the healthcare policies, and also it also affects the issues because I think we've almost reaches to put the HCV antibody test into the mass general program, but anyhow it will be delayed and keep delayed. So I think that this issue, even though our hepatologists think that this is very important issue for the society health problem, but the magnitude of the importance the government has is we have very discrepancy between the government and the hepatologist, I think. And also the other issue we may have is even though most of the costs are supported by National Health Insurance for the DAA, but still the co-payment is quite expensive. And then it costs almost $3,000 even after the co-pay, even after the insurance. So some people still are not affordable for these expensive TAAs.
Please.
I think if it depend on the policymakers, maybe you cannot decide yourself because the government decides that you cannot do anything. So in my case, I try to do the best and then try to test every single person who come to my hospital because we have about 1,000 to sometimes 1,700 outpatient clinics, and the surgeon does the testing every single ones. But as I showed, only 40% in total. So we can make it 100% and they show the models to the other people to convince. And by doing that, you are not relying on, you don't need to be dependent upon the policymakers. That's my ideas, and so the way to go.
Thank you.
Dr. Omada, since you have the microphone, your remarks make me recall when we were having our conversation about this forum. You were saying I'm in a position to do pretty much anything I want at the moment, and I was curious.
Sorry about. Can you give me 1 minute? Yeah. Sorry about the government. Sometimes very enthusiastic about one things, but then fever's out. Yeah. So you got to do yourself.
Yeah, but I was going to follow up to ask you, based on your data, and the large number of clinics that you just mentioned, are there any kind of new directives you can give to the clinicians in those settings regarding the priorities for testing for hepatitis
The
C?
key is not telling the RNA positive, but by elastography or other method like a platelet counting, Apley score, FIB4, I tell this may be having a stage of F2, F3. So not just telling the like a GI, OBGI people or pediatrician by this patient, 10 years, not a 10 year, like 72 years gentleman, F3, so the maybe occurrence rate of cancer a year could be 1 to 2%, or maybe at most 3%. So I will add the comment, not just positive RNA. That's what I do.
Thank you. A question for Dr. Choi, and maybe this turn it over to Carrie James here. I was, Dr. Choi, governments make decisions for multiple reasons. One of them is financial. The other is political and influence by members of the public. And I wanted to get your view on what could get this decision over the goal line. Is it just more cost effectiveness modeling, or do you think it's more a role of community advocacy to send the message that this is what patients are seeking from the health system?
Yeah, I think even though we provide many times it could be cost effective, but government usually doesn't want to hear about cost effectiveness.
Okay.
And I think like Dr. versus some influencers, for example, some idol members or some famous teenager talents, if they got the HCV infection from the tattoo, if they were successfully treated the DAA, and they can be, I think, more impact than that we can, even though we keep saying, hepatology keeps saying HCV infection is very important into the audience, into the population, but I think there's some influencer or some famous YouTubers, they have a more impact than us. Then I think of collaborating with them also can be an option. But for the government, I think always the working with the government is all very, very hard. Yeah, and also still, again, the HCV prevalence in Korea is quite low compared to the other country. So mostly our government is more focusing on the hepatitis B rather than the Hep C. That is another barrier, then we cannot persuade the government.
Yeah. Please, Carrie.
Thank you so much. Hi, I'm Kerry James from the World Hepatitis Alliance. Thank you all for your presentations and the amazing work that you're doing. Just wanted to ask you a question about a pilot that's been happening in London, where they've been doing in emergency departments in all the London hospitals, they've been doing opt-out BBV testing for HIV, hepatitis B, and hepatitis C for all blood drawn in emergency departments. And they've been very successful in identifying all three. Actually, they're finding 3 times as much hepatitis B than anything else, which was a big surprise to everyone. But obviously, this can be a slightly controversial topic because it's opt-out and everything. So I just wanted your opinion on whether you think a program like that could be implemented in your country, or how do you think acceptable that would be in the APAC region in general? Thank you.
I've been working for the 3,000 HCV positive patients for 17 years. So I have a basic data in the areas, and I tell the risks of the developing cancer because they are the local people. So even though the emergency brought in the traffic accident, but they recover. So at the end, maybe if the patient's traffic accident, young drivers or 30s, I may say, well, in lifetime, you may have expectation of the occurrence of cancer 15%. Then I may ask the doctors to decide.
Question for Dr. Hu from Taiwan. That was an excellent presentation and really a great example of integration of hepatitis into the diabetes care system. It was quite remarkable, the high prevalence of hepatitis C among persons with diabetes in that part of the community. It brings to mind the relationship between hepatitis C and diabetes, of course, that hepatitis C can increase the risk of diabetes. And so that may be one of the reasons for the increased prevalence. But then it also brings to mind the multiple hepatitis B outbreaks we would get in the United States because of unsafe injection practices, as from glucose monitoring examples, such as in residential care facilities for the elderly, et cetera. So just wanted to get your thoughts about what were the reasons for that high prevalence in these areas.
Yeah, the high prevalence of Hep C in diabetes might be resulted from the atrial hepatitis manifestation. But it is not limited to diabetes. In our data, you can see that more association to chronic kidney disease or cardiovascular disease. However, the close association is not seen in our data for hepatitis B. So I think for CKD and diabetes, they belong to atrial hepatic manifestation. If we treat all the comorbidity, we can stop the progression of chronic kidney disease or diabetes control. That would be cost-effective, universal when compared with universal screening. Especially the diabetes or CKD patient are maybe older than general population in general. So in our experience, maybe for cost effective, we only have to surveillance for a patient older than 40 years or 50 years. It is enough to achieve the elimination of HCV. And yeah, so the comorbidity is very important for elimination, is our experience. It is very cost effective when compared with universal screening.
Since Egypt was brought up earlier, as you probably know, Egypt integrated their hepatitis C screening with diabetes screening and obesity screening. So there was a relationship there, but not to this level of actually integrating diabetes care with hepatitis C care. So it's really an excellent, again, example of integration.
The other reason for diabetes and CKD patient, since in Taiwan, we have co-care system for the CKD and diabetes populations. So the co-care system has already been there. So there are complete list for those patients with regular visit. So the thing we only can do is just plus HCV testing in their regular visit. It is very simple, no duplicate of paperwork, and there's no extra patient visit.
There used to be the studies by saying HCV induced diabetes. There is a molecular biological studies, but then we eradicate the virus. But I don't see the tendency that improves. So, etiological basis, it's very hard to believe now clinically the HCV induced diabetes. So maybe there is some other reason why you have very high incidence on that you are diabetic.
Maybe, however, in our data, we always show the prevalence of HCV infection in diabetes is 2 to 3 times of general population. In any other surveillance, either in geographic or
Sorry, how much I missed? 2 times, 3 times? How much percent in the absolute?
6 to 7%.
Oh.
So I have a question for Professor Ikegami. In your presentation, I saw that the anti-HCV prevalence rate increased from 2015 to 2020 in the Department of Orthopedic or Ophthalmic. So it's quite interesting why this patient, the outpatients outside the specialist have an increase in the anti-HCV prevalence.
Thank you very much for your question. Actually, the number was just on HCV antibody positive persons. Actually, we screened that persons after getting the test result with the PCR. So around 10% or something of all HCV positive persons are as inactive. They are active. They have active infection. So I'm not sure why the end of the series the number of the HCV positive patients are increasing, but probably just after the pandemic, maybe the many or elderly persons that visit the hospital. Probably, I'm not sure about that. The reason why the prevalence of HCV positive antibody positive persons are increased at age, but the actual number of active infectants are pretty low, even in that the pre-operative tests are positive persons.
Okay, thank you very much.
Same question. Thank you.
Oh.
Anything else?
Anything else? I think we almost are run out of time. I would like to thank all the speakers and also the audience. And thank you very much. And and finally, I would like to invite Dr. John Wall for the final session call to action and give us a closing remark.
Thank you. Thank you again for excellent presentations and excellent discussion. As I mentioned at the start of the forum, we really wanted to recognize how the importance of keeping hepatitis elimination as a top of mind goal around the world. And we've heard multiple reasons for why that has to be the case so that we can sustain good programs that you've heard about from Taiwan and from Japan and from Singapore, while we need to help other countries that I touched on, such as Vietnam or Myanmar or Bangladesh, Pakistan, get going through sharing lessons learned and validating their direction. And then recognizing the importance of working together, such as the partnerships that are represented in this room, actually, academicians, clinicians, public health officials, industry, community leaders, all play a role. So we thought it would be fitting to end our forum, with a call to action to exemplify our shared commitment toward hepatitis elimination. And then we could then use that call to action to send to ministries of health or to other key stakeholders to show, like, this is a really important issue. You have an important, influential constituency that's committed to it, and then people will take note more so than they are currently. So we put this together, and I'm going to ask all of you, if you agree with it, to come forward, as sign a version, and we have a pin for you while supplies last. But basically, the call to action is that, as a group, we're concerned about hepatitis elimination in Asia, that we're calling, as we've heard, about the WHO global strategy with goals for hepatitis elimination that have been endorsed by all member states in the World Health Assembly, recognizing that we have achievements to build on that we've heard about today, in part recognizing government's commitment to hepatitis B and hepatitis C elimination, demonstrating the feasibility of putting together effective programs with that commitment. Also recognizing other achievements, such as Asian countries reducing to less than 1% the prevalence of hepatitis B surface antigen through high hepatitis B vaccination coverage. The only UN Sustainable Development Goal achieved in 2020 was this goal, in large part because of the work of Asian countries. The robust toolkit that we've heard about today of strategies and technologies that simplify hepatitis C testing and linkage to care in particular. And the prospects for functional cures, which we're hearing about at APASL, and the lessons learned from research and new policies that we'll be hearing about on Saturday that hold promise for expanding access to hepatitis B testing and treatment. However, we note with concern, as I touched on, that over half of the 350 million people with hepatitis B are living in Asia, that only 1 in 8 persons with hepatitis B are diagnosed, only 1 in 30 are receiving treatment, only 1 in 5 persons with hepatitis C are diagnosed, only 1 in 10 are receiving treatment, and the loss in productivity as a consequence of that premature mortality and disability is harming economies in Asia. So we'd like to raise awareness that hepatitis elimination can be contributors to national productivity, which will be of interest to national governments, that hepatitis C elimination can have profound health impact and improved health through reducing disabilities. And so the call to action calls on governments to have good data to assess their burden of hepatitis B and hepatitis C, including access to testing and treatment. Use those data to develop effective action plans with financial strategies to put those plans into place. Sustain coverage of what's working already, such as hepatitis B birth dose vaccination to prevent mother-to-child transmission. To update and implement policies based on new data and revelations of what can work more effectively in their countries, engaging all stakeholders, including the importance of engaging civil society who have the most to benefit from those policies and are at greatest risk of harm when those policies are not put in place. To meet targets for high-risk populations, such as persons who inject drugs, and always look for ways of building partnerships to engage public and private partners to provide resources and expertise. And encourage legislation to end discrimination such as stigma, job restrictions, et cetera, that harm people and make people feel like the risk of knowing one's status exceeds the benefits. Then we call on clinician organizations, including APASL, to recognize the need to strengthen specialist and non-specialist provider skills so you can decentralize hepatitis care into health systems, expand guidelines so that you can expand access to hepatitis B and hepatitis C treatment, recognizing that the expertise such as in APASL has critical roles to play in developing that national policy. And we heard examples of that here in the forum today. Promote integration with other clinical services. Again, we just heard an excellent example for the diabetes and HCV treatment services, and then have those networks set up so when those more complicated patients can be referred to specialists such as hepatologists. And then recognizing that operational research is needed throughout the journey toward hepatitis elimination. It's important for all of us to participate in that to see what's working and what's not and how it can be improved, and to have communities of practice such as what's represented in the room today to share lessons learned. And then for communities, convene local coalitions to launch programs and sustain political will for hepatitis elimination. And those coalitions need to include all stakeholders, such as all of us in our room today. Raise awareness of the threat of viral hepatitis and the benefits of hepatitis elimination. Government officials, and including the transition from one government to the next, you have to be in a continued education mode to raise awareness of why this is important and look for those opportunities to have an impact in policy development. And then again, seek ways to reduce stigma at the community level, providing other assistance for persons with hepatitis, in their families. And then through all of that, recognize all of our roles that we are seeking to play and have respect for those roles, whether it be clinicians, health officials, community leaders, industry, and political leaders. And that really are seeking to have a sense of unity of purpose, and that we share a commitment of working together to goals for hepatitis B and hepatitis C elimination achievement. The QR code is to join the call to action to eliminate hepatitis in Asia. You can read it here electronically. We have versions of it here. And so I would appreciate if you, for those that agree with it and have time, please come forward and sign it. Thank you very much. Come forward and show that you're part of the global coalition to eliminate hepatitis by signing this call to action. I think that would be a great show of support and a fitting way to end this forum and to be a product of this meeting of APASL. Thank you.